Just to let everyone know what we will talk about in a minute when we get started, I will go through how you're going to access your continuing education credits. After the webinar, we will talk about how we're going to proceed today with questions and answers, and we'll introduce our speakers for you in just a minute or two. Okay. So we still have a couple folks trickling in, but I'm going to get started. My name is Fiona LaRosa Waters. I'm the Director of Business Development for Reasons Eating Disorder Center. Really excited to be co-hosting with Rock Recovery today. I will defer to Kristen and Elise to talk a little bit more about Rock, but they're an incredible organization. We're just thrilled to partner with them this year. Had a blast working with them on this webinar, just like excellent work, excellent teamwork, and excited to introduce our Reasons audience to Rock and to introduce ourselves to the Rock audience. So a big shout out to them for their collaboration on this. It's been a lot of fun, and I think we have a really great presentation for you all today. We're going to be talking about group therapy in treatment across levels of care for eating disorders, and our two presenters are Elise Thibodeau and Anna Governale. We're going to ask to save questions for the end. You'll be able to use either the Q&A box or the chat box to send in questions. You'll see those on your screen. You're welcome to send them throughout. We'll be monitoring volume to see how much time we think we want to save for the end. And then Kristen's going to facilitate the Q&A after our presenters are done going through slides for you. So send those along throughout. And if you have a clarifying question, something needs to be repeated, etc., send it along. We'll be monitoring and we will interrupt and send you that question. Or if you're having any technical difficulties, of course, please let us know in the chat box. As far as your continuing education credits go, what you'll receive not long after completing today's session is you'll get another email from CEGO. That's the organization that's hosting this. They're the ones who sent you all the reminder emails once you registered. CEGO will be sending you a post-course evaluation through email, and attached to that will be the slides for this presentation in PDF format. So for folks who are looking for the slides, you'll get those after the course as well. Once you complete your online evaluation, you'll get instructions on how to download your CEs. If you have any difficulty with that, I'm going to put my email address in the chat right now, and you can reach out to me if you have any technical difficulties accessing your CEs, if you don't receive the after course evaluation, anything like that, don't hesitate to reach out. I think that's it for housekeeping, continuing education, and CEs. So I'm going to go ahead and get started and introduce you to Anna. So Anna's been a part of Reasons for a number of years at this point. She's absolutely wonderful. She's worked at multiple levels of care for us. Reasons, for those of you who know us, we're an eating disorder treatment facility in the Los Angeles area. We're part of BHC Alhambra Hospital, a specialty program that's part of that hospital, which means that we have a very strong psychiatric component of support to what we do, including an inpatient unit for co-occurring psychiatric and eating disorder needs, which is pretty unique, and I think something that makes Reasons really special. We have 3 residential houses in Los Angeles as well, and we have currently virtual telehealth, PHP, and IOP. That was a change we made last spring because of COVID-19. We would be thrilled if you would ask us any questions you have or reach out. There's going to be an information slide about Reasons as well in the presentation that you'll receive, and contact info for Anna. I'm going to tell you a little bit more about her now. So Anna completed her undergraduate degrees in psychology and religious studies at the University of California in Santa Barbara. She subsequently began working in the mental health field as a mental health worker at Residential Treatment Center for Eating Disorders for 5 years while acquiring her master's in clinical psychology. She completed her master's program at Antioch University in Los Angeles. After graduating, Anna began working at a community services agency serving underprivileged communities in the inner cities of Los Angeles and providing in-home services to children, adolescents, and families. After gaining experience working with this diverse population for 3.5 years, Anna realized that she missed working with eating disorders, and it was her true calling and something she was genuinely passionate about. She came back and started working at Reasons in May of 2011. First as a program therapist, then as the program manager for the inpatient, partial, and intensive outpatient programs at BHC Alhambra. Anne is currently our program manager for the Hancock Park Residential Program and the Reasons Director of Training. She's DBT trained and pulls from a variety of therapeutic orientations in her work with clients to assist them in their journey to wholeness and healing. I'm going to hand it off to Kristen to tell you a little bit about Rock and Elise, and then we're going to get started with our presentation.
Thank you, Fiona. As Fiona said, we are, can you hear me? You guys hear me?
Nice.
Okay. So as Fiona said, we're excited to just be
part. We can't hear you. I can't hear you. Can everyone else hear Kristen?
On and off.
Oh, something's wrong with my computer. I'm sorry I interrupted.
That's okay. But we're really excited to be partnering with Reasons and to be talking about group treatment, especially with Elise, who is one of our volunteers turned director. And then she's come back to work with us as a therapist. So I'll introduce Elise in a little bit, but just to give you a little bit more background information about Rock Recovery and who we are. My name's Kristen Soto. I'm the Director of Community Partnerships at Rock Recovery, and I've been with the team for just over 3 years. Rock is a DC-based nonprofit. We were founded in 2009. And our mission is to bridge critical gaps in treatment for individuals 18 and older who struggle with eating disorders. We offer a variety of outpatient group care, and we serve residents in Virginia, DC, Maryland, and California. Elise is going to go into our group offerings a little bit later, but some of what we do includes meal support and group processing, body image therapy groups. We offer a faith-based processing group, and we also offer a recovery group for moms who are seeking recovery. In addition to offering clinical outpatient groups, we also do community support and community empowerment events where we're able to serve people nationwide by offering recovery resources. We're able to serve parents and families, and we're able to partner with treatment centers to offer these amazing events like this one. Getting a little bit into Elise's bio and her background with Rock Recovery. So Elise joined the Rock team back in 2013 as a volunteer therapist with one of our first groups. Since then, she has served the Rock community in a variety of different capacities. And up until 2016, she moved out to California, and we were excited to bring her back onto the team with us in 2020. Elise has been providing eating disorder therapy for the past 7 years, and she's worked in a variety of levels of care ranging from outpatient to residential. Elise is a licensed professional clinical counselor in the state of California, and she is a certified eating disorder specialist supervisor. In addition to working with Rock, Elise runs her own private practice in LA called Abundant Life Therapy. And just as a clinician, Elise is really driven by a passion for freedom and for holding hope for individuals who are seeking recovery. So we're really grateful to have her do this presentation with us. I will also drop my email in the chat box, so if you have any questions about Rock services or want additional information, you can reach out. With that, I will turn it over to Elise and Anna.
Great.
So sorry about this. I'm just struggling with the screen share a little bit because I am trying to figure out how to forward. Let me try this again. There we go. Is that working for everyone?
Yeah.
Sometimes it freezes and we just have to exit and enter again.
All right. Can I go ahead and get started, Fiona?
Go right ahead.
All right. Hi, everyone. My name is Anna. So I'm going to be starting the presentation and going over the overview with everyone. So Elise and I are going to take turns in the presentation. So we're going to start with group theory applied to eating disorder. I'll be covering the stages of group, and Elise will be covering therapeutic factors. And then we're going to transition into, sorry, Fiona, can you go back one slide? Sorry. Then we'll be transitioning into eating disorder groups across levels of care. I'll be reviewing inpatient and residential groups, and then Elise will be reviewing PHP, IOP, and outpatient groups. Next slide. All right. So some of you may already be running groups, but I'm just going to run through this for everyone in case you're not familiar with group theory and group development. And then also some of the things that do come up in eating disorder treatment specifically. So there's 5 stages of group development, and they are forming, storming, norming, working, or sometimes called performing, and then adjourning. Next slide.
I'm sorry, it keeps freezing.
That's okay.
I apologize to everyone for the technical difficulties.
Fiona, do you want me to just use the slides that I have and then you can catch up?
That might need to be what we do because I keep having my controls freeze when I try to forward slides.
Okay. Everyone will be getting a copy, correct?
Yes.
Okay. Okay, so let's just do that for the sake of time.
Anna, I can screen share on my end too. I have the full PowerPoint.
Okay, do you want to do that?
Yep, I will get that going.
Thank you.
Fiona, can you stop sharing your, okay, there we go.
Yeah.
Okay, so first stage, we're on the first stage of group development of forming. All right, so forming in this stage, it is the orientation phase. So this is where the group leader therapist is most active. Universal norms are discussed, such as confidentiality, attendance, and rules of communication and participation are also addressed.
So for a lot of times for the clinician or group leader, it'll feel like they're working harder than the patient or clients, especially in the higher levels of care where patients are pretty resistant, not wanting to be there, not wanting to participate. This may cause
to get frustrated, especially with an ever-changing milieu or group in the treatment settings. The average length of stay for inpatient and residential is 30 to 45 days and 4 to 8 weeks for partial intensive outpatient programs. So that really just varies on the individual patient's progress, the way they go through the treatment process. Some patients may progress more quickly than others. Some may need to be stepped up. Let's say they're impartial or IOP and they're struggling, need to step up to a higher level of care. So those are just kind of the averages. In outpatient group settings, the group leader has much more control over the group, including who will be in the group, length of the group, and whether it's a closed or open group. So I'm also a clinical supervisor, and this comes up a lot in regards to confidentiality and group therapy. So I did want to touch a little bit upon that. And there may be differing opinions. This is how we approach it in Reasons and found it actually to be extremely helpful. So in a group setting, confidentiality is to the groups. All group members are asked to pledge confidentiality initially when they admit into program to the group, which includes not talking about what was disclosed in group outside of the group setting, particularly with others who are not part of the group. So they're not supposed to be discussing with friends and family members that they call. They're not supposed to be discussing, with one another outside of the group session. Really, processing outside of the group is not encouraged. They can definitely offer support to one another, but we're encouraging them to not process outside of the group. In a treatment setting, what is discussed in individual therapy is absolutely material for group process. So individuals are informed in session when they first admit that what material is appropriate to be brought into group. And furthermore, if patient is avoidant of processing in groups, the therapist may inform patient that they will be encouraging patient to bring avoided topic into group during the group, hence decreasing avoidance. So I'm going to talk a little bit further about this and elaborate on the Reasons philosophy, specifically in implementing exposure therapy and how this relates to that. But the confidentiality is not specific to the individual therapist, and then they're not bringing that into group, unless it's specific details of trauma or things of that nature that aren't really appropriate. They would be discussing pretty much everything in the group therapy setting. A hallmark feature of eating disorders is shame. It's intense, all-encompassing, debilitating shame. Shame thrives in avoidance and hiding, and it's the group leader's role, specifically the therapist, to bring hidden parts into the light. Some therapists may have difficulty with challenging patients to bring themes from individual therapy into the group, and it is important to have a clear understanding of why this is not only relevant, but necessary. Again, this is specifically related to groups and treatment. I have run outpatient groups, but in this type of setting, the higher levels of care, we're a lot more confrontational and challenging to decrease avoidance and have the means to contain any type of activation or emotional regulation that may ensue after the groups. Confidentiality is held to the treatment team as well, and the group, not a specific clinician. This is in line with the most multidisciplinary team approach. So we are discussing as clinicians pretty much in depth everything that's discussed in the group sessions. We're continuing to deepen the process in the next groups. We're informing our experiential therapists, our dietitians, anyone involved in patient care, the themes that are coming up in group and why it's relevant to the specific patient and the group in general in terms of interventions and patient care. Stage 2 is storming. So this is a transition phase. Anxiety, ambiguity, and conflict become prevalent as group members test and act out behaviors to define themselves and the group norms. This stage creates an interpersonal environment where members should feel free to disagree with each other. Patients in this stage or clients will also most likely disagree with the therapist. This is always fun. This is the stage where a lot of externalizing plays out on the therapist, the staff, the program, group members. Any of you who have run groups and experienced this know exactly what I'm talking about. It can create a group mutiny dynamic if the therapist is not skilled in reining in the group and regulating individual group members. In treatment, fortunately, we have the support of other staff members. So that's, I think, one of the beauties of doing group in treatment. Group members should be encouraged to speak to what the underlying frustrations are and will oftentimes need the therapist to point out dynamics or themes that may not be easily identified or observed by the group members. Frustration with peers, other group members may get projected onto the therapist, which should be reflected back to the patients and or clients. And they're also discussing this in individual therapy, exploring it further, and then coming back to group. Family dynamics will oftentimes play out in the stage. Group and treatment provide an environment where larger macrocosm of the family dynamics get acted out in the smaller microcosm of group treatment. Patients can get discouraged in this stage, and if not properly handled by the group leader or the program, can ultimately, unfortunately, result in an AMA discharge, which stands for against medical advice, which can lead to other patients also wanting to discharge. So definitely not a good situation or dynamic. The third stage is norming. So this is the cohesiveness phase. Members develop group-specific standards or cohesiveness, and a therapeutic alliance forms, such as disproving late arriving members or level of anger conflict that will be tolerated. Group members can tolerate disagreement with one another and group leader in this stage. Confrontation is more tolerated. So a group member calling out another group member on a behavior or for not showing up for the group is more acceptable or tolerated. New members that join the group due to another member discharging conform more quickly to group norms and standards, and less time is spent typically in the storming phase. Again, this is specific to groups in treatment where members are coming and going fairly frequently and have varying lengths of stay. Higher functioning group members will often challenge less or lower functioning group members, which can be tremendously more beneficial than the therapist or group leader alone challenging them or engaging them in the treatment process. Stage 4 is working. This is the performing phase. So during this stage, individual growth and team productivity and effectiveness occur. Members experiment with new ideas or behaviors, and egalitarianism develops. So in this stage, group members are engaged in processing more independently within the group with less prompting from the therapist or group leader. For didactic groups, members are also more engaged and demonstrate more openness and willingness to participate. Some groups never evolve to the working stage, but that's not to say that significant, meaningful work doesn't happen at every stage. Increased vulnerability, group members are more readily disclose threatening, shame-inducing material with increased insight. They acknowledge reactions and perceptions, clear up projections and misunderstandings, and work through any possible conflict. Clear and direct communication by group members is observed. There's also a lot less not need for the therapist, but they're more processing independently in the group, within the group, without the therapist having to prompt as much. And this final stage is called adjourning, and this is the termination or consolidation phase. So the closure for the group as a whole, which never really happens in inpatient or residential or PHP or IOP, that's more specific to outpatient groups, or for the individual that has left. The primary task is to discuss and review actual outcomes and achievements, explore feelings of what worked and what didn't, and any feelings of loss. Introducing new concerns or initiatives isn't appropriate at this stage. In treatment, this usually looks like a group member leaving the group due to needing to discharge, either because of insurance reasons or successfully completing a current level of care. At times, patients will also leave against medical advice. In all situations except for the last ones, group members are provided a goodbye group. This is more specific to reasons for a patient to consolidate the treatment process. Group members have an opportunity to say their goodbyes, including anything that they learned from the departing group members or any concerns they may have for that specific person. Group members are also encouraged to express concerns for a member who is leaving against medical advice, although they don't get a formal goodbye group. Group dynamics shift when one group member leaves, at times dramatically. Sometimes group will go through the stages of group development again as the group adjusts to the changing dynamics. So I'm going to turn it over to Elise now. Sorry, I know that we went through that very quickly. If there's any questions at the end, I can go give examples, things like that. So I'll turn it over to Elise at this time.
Great, thank you, Anna. So I'm going to be discussing the therapeutic factors that we see in groups, and there will be a little bit of overlay from what Anna shared. These are how therapy happens in groups. And I got these from Yalom's book, The Theory and Practice of Group Psychotherapy, one of the most important books, I would say, about group therapy. And he says that these factors are the basic factors that make therapy effective in general, any kind of therapy. And what I'm going to discuss as we go through each of these is what the factor is, what the factor looks like in the group setting, why each of these is really, really important for eating disorder work in particular, and then what the group leader can do to sort of facilitate each of these factors as they show up in groups. So the first factor we'll talk about is the installation of hope. What this looks like is it's a high expectation that change is possible, right? Recovery, growth, freedom, that these things are possible. And this is a really powerful, group is a really powerful way to instill hope, because group members are at different stages of healing. So you'll have a group maybe with people who are just realizing that they have an eating disorder that they want to work on, in the same group as people who maybe been in recovery for 2 or 3 years or more. And so group members get to see other people further along in the process of recovery. And they get to witness other people's progress, either through spontaneous testimonials or planned testimonials. You know, sometimes we'll have groups around people sharing their stories, and that can be really, really inspiring to other group members. This is really important for eating disorders because there's a high level of ambivalence oftentimes that we see in clients with eating disorders, and recovery is such a long process. And a question that I've seen clients ask in various different ways is life actually better in recovery? There can be a long stretch of time between someone's decision to pursue recovery and get better and when they actually feel like a sense of freedom. And so really being able to maintain hope that it is better on the other side is really, really important. So the tasks of the group leader here are orienting clients to group with positive expectations, correcting any negative preconceptions, believing in themselves and believing in group. Oftentimes when I'm supervising therapists, one thing I'm really mindful of is this therapist losing hope for a particular client or their work with them or for the group process or for recovery? That's something that I think we as clinicians always really need to be asking ourselves and asking each other, so that if we are struggling with that we can kind of recalibrate. And then therapists, I love doing this, calling attention to group members' progress and eliciting testimonials. So really encouraging people to share their progress so that can be inspiring to other group members. The next factor, universality. So this is just that idea that we all experience at the end of the day a lot of the same things. There is no human deed or thought that lies fully outside the experience of other people. And in group that becomes really clear as group members hear each other share. They can have these moments of like, wow, I thought I was the only one, and hearing someone else express the same thought or feeling is so comforting and really powerful. And I think this can happen a little bit in individual work. We can normalize their experiences, but you know, in some cases we might even self-disclose that we can relate on some level, but that's going to be pretty limited, right, compared to the universality experienced in groups, because therapists are not going to be self-disclosing all the time. And this is, of course, very important in eating disorder treatment, because we see that our clients are very often struggling with shame and with isolation. So Yalom in his book doesn't actually talk about eating disorders specifically very much, but he does talk about clients with eating disorders in his section about universality. He says that clients with bulimia are a group for whom secrecy has been an especially important and isolating factor. So very, very important with this population. And the tasks of the group leader here are just going to be, you know, some basic process questions around like, who else has felt this way, to really elicit a sense of common experience. And just a little bit, a note here about diversity. It's very, very important as the group leader to really have an awareness, and education, and training around diversity, because clients may have a pull toward feeling like I'm the different one. If there is a diverse group, they might feel like they're the only one at a certain life stage, of a particular gender, the only one with a certain diagnosis, the only one of a certain culture, or only one in a particular body type. You know, if there's body diversity in the group, that can be really challenging for people. And to be aware of aspects of diversity, different cultural attitudes about disclosure and interaction. The leaders, it's really important for us to be simultaneously aware of those dynamics while also drawing on universal themes of human experience. And that can be kind of a nuanced dance, I think, to not invalidate the experience of clients who are marginalized, while also drawing attention to universal themes. So next we have imparting information. So this is just psychoeducation, and then also direct advice, guidance, and suggestions. So group therapy is a really efficient and effective way to provide education and guidance. You can have 8 different individual conversations with 8 different clients, or you can provide education very efficiently in a group setting. And then group members can also add feedback and education that a leader might not think to include. And now as an outpatient therapist that I used to work in higher levels of care, and now I just do outpatient work. When I am referring clients to higher levels of care, I get really excited about how much they're going to learn about eating disorders and the recovery process and what kind of challenges to expect, et cetera, in the groups in treatment, including dietary things as well in dietary education groups. All foods fit, health at every size, what to expect when normalizing the relationship with food, what to expect if they're going through weight restoration. There's so much education that we can provide. And so the tasks of the group leader here are going to be noticing and anticipating opportunities for imparting important information, and then providing the group with some norms, or helping facilitate the group discussing norms around advice giving. This is something that can be not as effective with direct advice giving from peer to peer. It's more effective when group members kind of give advice that's starting with like, well, for me, you know, when I was going through this or experiencing this, this is kind of what I felt and how I got through it. That can be a little bit more effective than, you know, telling their peers what to do. So providing norms around that. Altruism. So this is benefiting from giving to others. So realizing that, you know, a client can realize they have something to offer other people, and it's engaging in a reciprocal giving and receiving cycle. Excuse me. So how this shows up in groups. Group members can give and receive with one another in a way that individual client therapist dyads cannot. As therapists, you know, even if our individual clients are trying to give to us, it's of course not appropriate for us to receive in the same way that peers can receive from each other. So there's much more opportunity for clients to practice altruism in a group setting. This is important in eating disorder treatment. What I've seen really a lot with eating disorder population is sort of extremes of self-deprecation and self-obsession, sometimes at the same time. And maybe sometimes yo-yoing between these. And what I mean by self-deprecation is like, I'm less than everyone else, I'm shameful, I'm unworthy, my only value is trying to put others before me. And so really having these people-pleasing tendencies, and like maybe people won't realize how bad I am, that kind of mindset. And then a self-obsession of all I can think about is how I look, how I'm coming across to people, what I'm going to eat next, hours spent body checking, comparing myself to others. So in these mindsets, there's not a lot of room for kind of a reciprocal giving and receiving relationship. And so that's so important to practice to move out of these spaces. And so a group leader can really help to point out to clients where they may be really, really people pleasing without ever receiving, or vice versa, and really helping clients shift between giving and receiving and having that reciprocity. Next, we have the corrective recapitulation of the primary family group. So this is re-experiencing childhood familial issues or concerns with a repair. So testing out new belief systems, new ways of relating to others. And this shows up in groups in that groups resemble family units, with leaders being like parents or caregivers, and other group members being like siblings. And the way clients show up in the group is likely very similar to the ways that they show up in their family of origin. And that might look like vying for attention, trying to be the peacekeeper, taking up as little emotional space as possible, that kind of thing. So, and they also may engage with group leaders the way that they engage with their parents. They might be rebellious, they might be distrusting, they might be people-pleasing. So always important to be aware of those things as leaders as well, how a client's interacting with us. And this is really important for eating disorder treatment, because we want to be looking at healing early wounds and early patterns. This can be really crucial to the recovery process. And, you know, these early family experiences or current family experiences, they can be really varied. Some people have, you know, big T trauma from their families of origin. Others may have, you know, developed insecure, anxious attachment, some struggle with appropriate boundaries. So all of these things can be sort of recapitulated in the group with a repair. So what we want to do is support clients moving from the rigidity of this is how I show up here to flexibility, to getting to try out different ways of being within the family unit of the group. So it's really important to make sure we have that corrective piece, not just the recapitulation. Next, we have development of socializing techniques. So this is learning how to resolve conflict, to communicate, to respond with empathy toward others. And groups, of course, are going to give a lot more opportunity for here and now socializing skills than individual work can. This is important for eating disorders because they'll often function as maladaptive communication strategies. And what I mean by that is, you know, behaviors or body changes too can be signals to people, you know, something's not right, when a client maybe can't communicate that for themselves. And I've often heard clients say, you know, I liked being in my eating disorder because my outsides matched my insides, you know, and part of that work there is, okay, how can you communicate that verbally and get your needs met more effectively, really, because you're really communicating more effectively what's coming up for you. And the tasks of the group leader here are providing psychoeducation about assertive communication and coaching members as they practice conflict resolution. there's a lot of different formats people use in different treatment centers and groups for assertive communication, but fundamentals are the same, you know, speaking to your own experience and feelings, refraining from assumptions of other people or blaming or judging others. Yeah, we can go to the next slide. Imitative behaviors. So this is walking, talking, thinking, acting like another. And in groups, we have more opportunities for modeling. You know, in individual therapy, we might see clients model the therapist or imitate the therapist, but they can also practice imitating their peers and trying on different things. And there's also what's called vicarious or spectator therapy, where one person in the group might be processing through something with the group, and another person who can relate is kind of vicariously benefiting from that. This is important for eating disorders because, you know, it creates flexibility and movement away from old patterns. Clients might be stuck in particular patterns of eating, of thoughts about themselves, and it might be tough to distinguish, you know, the eating disorder from their healthy self. And so imitation provides opportunities to kind of try on different behaviors, personas, thought patterns, that kind of thing. So as the group leader, we want to be modeling empathy, self-disclosure, boundaries, etc. And we also want to be noticing where imitation might be problematic. Sometimes eating disorders can compete, I like to say. And so if there are, if imitation is happening more in a negative way, to really be noticing that and helping the clients process through what that is like. Interpersonal learning. So this is building awareness of interpersonal challenges and one's own contribution to interpersonal difficulties, coupled with practicing new ways of relating. So the group can be conceptualized as a social microcosm. So essentially, the way clients are showing up interpersonally in the group is a window into how they show up interpersonally in the rest of their lives. And oftentimes they are unaware of their own patterns until they are reflected back to them in the group setting. One example of this, I had a client in an outpatient eating disorder group who would process about the various people in her life just not showing up for her or offering her the support she desperately needed. And the group initially was offering her a lot of empathy about this and like, yeah, we get it. Like, it's so hard when loved ones don't show up in the way we need them to. But as the group progressed, there were repeated moments of the client kind of soliciting support or feedback or advice from the group and getting it, but then rejecting it and essentially saying yes, but to everything. Until eventually, as the leader, I invited the group to kind of share with her what it felt like to hear deflections of their support. And the members were able to reflect that behavior to her. And that helped her to shift not only in the group, but in her life, like, oh, I'm contributing to people not showing up for me. So this is important in eating disorder treatment because eating disorders can be conceptualized in terms of maladaptive interpersonal behavior and relationships. I'm actually doing a larger presentation more fully on this topic as one of the IADEPT CEU events this year in July. But to be brief here, underneath the surface of the eating disorder behaviors, we typically see the functions of the eating disorder are really largely interpersonal. Communication issues, like I mentioned, self-esteem, other esteem, role confusion, trying to get needs met like love, admiration, attention, sex, control, safety, connection. Yalom actually says we can conceptualize all mental disorders in interpersonal terms, but we definitely see that in eating disorders. So the tasks of the leader here are fostering an atmosphere of safety and engagement. So safety, you know, if I were to ask that question of the group that I mentioned and it wasn't feeling safe, a client would have a really hard time hearing feedback about that, right? And clients would have a hard time giving it. And so the group needs to be at a certain stage for that to really be effective. We want to be modeling empathy for group members. We can't hear feedback if we're not feeling understood. So modeling empathy, noticing and reinforcing subtle interpersonal changes. Interpersonal change is so hard for all of us. And so if clients are showing just little glimmers of changes, we want to be really reinforcing that. And then we need to be self-aware as the group leader. We have interpersonal reactions to clients too. And oftentimes it's up to us as the leader to break the ice on giving actual interpersonal feedback, because it's not a socially normal thing to do. So it can be uncomfortable. But we really need to be doing our own work to make sure we're not reacting to a client out of our own stuff or our own countertransference. So next, we have group cohesiveness. So this is essentially the group therapy's equivalent to the therapeutic relationship. Anna mentioned this when she was going through the group stages. It includes the individual's relationship to the group therapist, to the other group members, and to the group as a whole. This is important with our eating disorder population because building self-worth is a really key task in the recovery process. And it's very linked with a sense of acceptance from others or from the group. There's kind of a reciprocal relationship there between how we view ourselves and how we perceive ourselves to be viewed by others. And clients who feel this solid therapeutic relationship are more likely to stay in treatment and in group. So the tasks of the group leader here are challenging scapegoating. So if the group is kind of ganging up on somebody out of discomfort and kind of blaming the group's problems on one person, to really redirect that. And then modeling healthy repairs when the group leader is actually being confronted. And a group that can express negative feelings toward the therapist is a cohesive group, Yalom would say, and because there's safety there in allowing for conflict. So it's really, really important here that the therapist responds in a way that creates safety around conflict. Next, we have catharsis. So this is experiencing and releasing strong emotions, often those that have been repressed. So this shows up in group, just the interpersonal process aspect of group. The release is witnessed by the group, and there's something really valuable about that. And this is important for eating disorder clients because behaviors often function as a way to either numb emotions, like collude in that repression of the emotions, or as ways to kind of replace emotional catharsis or kind of get it out, such as like a binge purge behavior. So when clients are moving away from behaviors and actually communicating their strong emotions instead, that decreases the need for the behaviors oftentimes, and then they're also more likely to get their needs met by themselves and others. You know, as the group leader, we want to be making sure that catharsis isn't just happening for catharsis's sake, that we're combining that with cognitive processing. There's a study that Yalom mentions that kind of looks at how essentially group members tend to feel like catharsis was a really important part of their group process, but there wasn't any indication that catharsis in and of itself actually led to better outcomes for the group members. So we need to be combining the emotional expression with cognitive processing around that for it to actually be effective. And lastly, the last therapeutic factor here is existential factors. So this is looking at coming to terms with certain facts of life and death, building meaning and purpose. This is, the facts of life are, things like life is unfair. There's no escape from death. There are certain things that I must face alone. And so I need to kind of take responsibility for the way that I live, and no one else can really do that for me. And this shows up in group through the process of developing intimacy and cohesion. Group members also realize that there are limits of how much others can actually help them. Some things they need to go through alone and really handle alone. I think this is really important for eating disorders because of oftentimes we see a bit of arrested development in this population, so some regression. I think in most eating disorder clients I've seen, this shows up in some way, even if they're, they appear to be very high functioning individuals. And it's most obvious in clients who have a very clear secondary gain of like parents or others caring for them while they're in their eating disorder. So being sick means that I don't need to get a job, go back to school, pay my bills, make decisions by myself, take care of myself, that kind of thing. Just an overall dependency. And freedom from the eating disorder then is kind of scary. So the group can experience, in the group, clients can experience this face-to-face realization of like the limits that of what others actually can and can't do for them and what they need to take responsibility for. So the tasks of the group leader here are just awareness of existential themes. I remember a particular group I was in as a client. One of the other members left the group abruptly and never came back. And people were reacting to this, and the leader of that group remarked that it was a bit like a death and that, we didn't get to say goodbye. And I remember that comment really allowing me and other members of the group to process times of loss in our lives. And that was made possible because that group leader was aware of opportunities to bring those kinds of themes into the group. So that is it for our therapeutic factors. And I'm going to turn it back over to Anna, and as we move into looking at eating disorders across levels of care.
Thanks, Elise. I'm just keeping my camera off because I don't want there to be unstable internet connection and for me to break up. Okay, so I'm going to be fairly quickly going over groups at the inpatient and residential level of care. Next slide. Okay, so I am just going to talk briefly about reasons, philosophy, and application in group therapy at the inpatient and residential levels of care, because I do think it's very important in terms of like how we run groups and why we feel like groups are effective. So we believe that eating disorders are disorders primarily of anxiety, but as we've already been talking about a little bit, also disorders of disconnection and shame. So in terms of how we approach group therapy at pretty much all levels of care, but particularly inpatient and residential, we conceptualize psychodynamically and treat behaviorally using CBT and specifically exposure and response prevention techniques as the foundation of our treatment approach. We approach all groups with intentionality. We're thinking about the individual in their own process, as well as a member of the group and the group as well as a process, how the group is processing itself in addition to the individual members. And we modify the group based on needs. So if the group is very high functioning, we'll alter, kind of the content or the concepts that we're bringing into group and vice versa. There's a lot of variety. So there's process-oriented groups, specifically addressing those underlying themes, didactic groups that are more psychoeducation, And those didactic groups take place across all the disciplines. So we have a nursing group that are psychoeducating the patients around the medical complications of eating disorders, dietary run groups where they're providing education around nutrition. And then also we have, other didactic groups are also some of the evidence-based practices. So we do have specific CBT groups, DBT groups, and then TRIM, which is trauma resiliency model type of groups, as we are a trauma-informed care, and so many of our patients do have trauma. And then we also have experiential-oriented groups. So yoga, dance movement, creative writing, drama therapy, so really treating holistically. So group members are working on identifying the motivating factors for their eating disorder at these levels of care, in individual therapy, which is then further elaborated on and explored in more depth in the group therapy. Group members are also acquiring skills, as I mentioned, to regulate emotions, teach distress tolerance, and challenge distorted thought processes. Groups consist of about 5 to 6 hours of our treatment day. We also have 2 hours of group process on Saturdays, and that happens 5 days a week at the inpatient and residential levels of care, whereas individual therapy only occurs 3 times a week. So a bulk of their treatment and work is done at the group therapy level. The main treatment modality is group process. So a little bit about exposure and response prevention and what that looks like in group treatment at the inpatient and residential levels of care. So exposure really is permeated throughout the treatment process, individualized versus generalized across patients and patient groups. So what that means is we're developing specific exposures on the individual level, but then we also have larger exposures that take place across the group in general. So what that can look like is an exposure snack, having them all process in group about a shame-inducing topic, and then more individualized exposures are going to be the things that the individual patient is struggling with, specific fear or avoided foods, specific situations. I mean, it could be a myriad of things and is really dependent on the person. As I mentioned already, common exposures include dietary, talking about shame-inducing topics. And then pre-COVID, we were actually doing a lot of exposures in the kitchen at residential. We don't have that luxury in inpatient, unfortunately, but in residential, there's a lot more dietary exposures and a lot more situational exposures. So we're taking them out into the community, having them eat in the community, having them eat alone in the house or even on inpatient, doing different types of challenges such as binge challenges, exposures where maybe we're leaving the restroom open to challenge their urges to purge, which may feel counterintuitive, but we really are preparing them to be more accountable for when they step down to those lower levels of care. The responsibility of the group leader is communication with other members of the treatment team, as I mentioned earlier. Observations, so communicating any observations that they see to the treatment team. Noticing where the patient needs to be challenged, having an awareness what the patient is struggling with in individual therapy, where the patient is being avoidant. Maybe that's not something that the other therapist knows, but more the mental health workers are aware of, or nursing or dietary. So we really are taking a very collaborative approach. We facilitate group in a way that intentionally and specifically challenges group members to expose themselves in the group setting in a safe way. Kind of piggybacking off of Elise's presentation on the therapeutic factors, taking all of those into consideration in terms of like how we are exposing them. And then the response prevention component is we are preventing them from coping with the intensity of their emotion through behaviors. So on inpatient, we have the restrooms locked. We have them locked in residential as well. But as I mentioned a minute ago, we may be doing a specific intervention for a person where we're keeping their restroom unlocked. And we want to make sure that their roommate, if they have a roommate, is also safe to have the restroom unlocked, or if we might have them in a room alone where they're able to challenge these urges. So locked restrooms, 15-minute safety checks, that's at inpatient and residential, and then multiple staff on the floor at all times. Specific interventions can be implemented based on the needs of the individual patient, including one-to-one staffing, increased checks, various protocols, and if needed, a behavioral contract. So all of this is relevant to group therapy because this individual is also participating in groups and is going to be getting activated by all of these interventions, the control they perceive is being placed on them. So while maladaptive responses are being prevented as much as possible, new skills are also being taught in group and in individual therapy in place of the old ones to help the patient regulate. These are taught in our didactic groups, which I already referenced, as well as rehearsed and practiced in individual therapy. So a group therapist may be reviewing a DBT skill of behavioral chain analysis. So she'll teach that skill to the group members. Then the individual therapist will reinforce that in individual therapy and have them utilize the behavioral chain analysis skill every time they have X behavior, for example. And then they're going to bring it back into the DBT group the next time it's in session and talk about kind of what they noticed. Research shows that in group therapies, it becomes easier to work on this common ground on exposure, which is one of the most beneficial techniques in CBT, because when cases are together with other cases experiencing similar problems to their own, a ground for working on many factors such as eating, weight, body, negative emotions, and interpersonal problems is developed naturally. I really like this quote. There's simply no pill that can replace human connection. There's no pharmacy that can fill the need for compassionate interaction with others. The answer to human suffering is both within us and between us. And that's from MISS Foundation founder and bereavement specialist, Dr. Joanne Cacciatore. And that brings us into eating disorders are relational disorders. So research shows us that individuals, this is specific for anorexia nervosa, but can cross over to the other eating disorder diagnoses, have problems with social communication and high levels of social anhedonia. In a research study conducted by Sparrow and Chanturia, the most common theme across all 4 group modalities that were studied was that patients enjoyed the social aspect of the sessions, which Elise referenced earlier. Sharing thoughts with others and listening to others' perspectives, group discussions, and the interactive or communicative aspect of the group were valued more highly by patients. Patients reported that the group felt like a safe environment for open discussion. Furthermore, this study found that patients enjoyed learning practical strategies for how to change thinking styles and behaviors and completing practical tasks. Eating disorders are relational disorders. So I referenced that in the beginning of this section. So patients have specified that their social life is the aspect of everyday functioning that suffers the most as a result of their illness, which is consistent with empirical data. Research results show that communication, sharing, and being with others were the most valuable aspects of the group from the patient's clinical experience. Patients who participated in group therapy were more open to engaging in conversations about change, which is huge, especially for this population. Group therapy decreases the member's sense of isolation and alienation, but in contrast to individual therapy, allows needs to be met without an individual becoming too intimate with or dependent upon one particular person, specifically the therapist. Psychoeducational formats provide group members with scientific information on the etiology, nature, effects, and course of eating disorders, as well as information on topics such as social factors, nutrition, and the potential dangers of dieting.
Anna, we had someone ask a question in reference to your previous slide. If you could just clarify which group modalities you were referencing.
I think it was in the research study, so I would have to, because I don't know them exactly off the top of my head. I know one of them was CBT, and then there was some other ones, but I don't know them right off the top of my head. But I could respond right after with that.
Sure. Thank you.
Is that okay? Okay, no problem. Continue with eating disorders or relational disorders. So in a study by Levine and Mishna, group therapy is often considered the treatment of choice for individuals with bulimia. While for a percentage of individuals, group therapy alone was effective, larger post-treatment effect sizes were associated with more intensive therapy and with concurrent individual treatment. Factors that moderate the effectiveness of the group therapy for bulimia: the therapist's empathy and understanding, Patients' contacts with other bulimics and work on underlying psychological issues were helpful factors in group therapy. In general terms, psychodynamic group therapy has been depicted as a holding environment that fosters nurturance, soothing, and tension regulation. Through processes of validation, self-empathy, mutuality, and empowerment, it is a setting in which bulimic patients can examine their problems relating to others both inside and outside of the group, thus fostering their being more authentic and less compliant with others' needs. From a self-psychological framework, the therapy group provides a safe space in which members can learn to understand each other and deal with relationships. It is regarded as particularly powerful in addressing developmental deficits and relational problems, in meeting self-object needs, and in promoting self-understanding, especially when empathic failures are experienced and worked through. The interpersonal context of the group allows members to examine their eating disorder symptoms in relation to interactions that take place outside or inside the group, and help them recognize, identify, and articulate the emotions the symptoms might represent. The group provides self-object mirroring, idealizing, twinship, and adversarial experiences. Through the microcosm provided by the group, the members are able to experience and examine interactions and emotions that are similar to those experienced in relationships outside of the group. Eating disorders are disorders of shame. I think, Kristen, were you going to jump in here real quick?
I can actually jump in. Yeah, so we're going to be transitioning in a few minutes, everyone, to the very last section of our presentation. So we wanted to ask folks, if you do have questions that you've been holding to the end, now is a great time to begin to send them in the Q&A box so that we can keep an eye on the time and strike a balance between, giving our presenters as much time as they need and saving enough time for questions based on volume. So go ahead and start to access the Q&A box with your questions. Kristen and I will be monitoring those, and we will be shifting into Q&A probably in about 10 or 15 minutes.
Thanks, Fiona. Okay, eating disorders are disorders of shame. All patients, regardless of diagnosis, are encouraged to openly share in group about struggles with behaviors, whether restricting, exercising, binging, purging, etc. It's been observed, and research supports, that an exposure-based approach such as this helps decrease shame, increase compassion for self and others, and a sense of feeling less alone. Group therapy combats the experience of shame stemming from bulimic symptoms through the opportunity to see as worthwhile others who are also bulimic and anorexic or binge eating disorder. I think that can be generalized across regardless of diagnosis. An empathic stance mitigates the shame associated with bulimic or eating disorder symptoms. And we believe, as Brene Brown states, shame cannot survive exposure and shame cannot survive empathy. The group setting provides an opportunity to experience a greater amount of empathy than just individual therapy alone can. Furthermore, empathy from those with similar struggles to oneself can be even more impactful. A little more on groups at the inpatient level of care. So group composition, despite level of care, is comprised of members at various stages of the recovery process with varying diagnoses, different age groups, and different genders, among other factors. Hallmark features of group members at the inpatient level of care, and again, this is a generalization, usually, and one of the criteria for actually being at the inpatient level of care is a lack of motivation. They're malnourished, highly ambivalent, actively engaging in their behaviors, whether that's eating disorder, a lot of times there's self-harm. There's high interpersonal conflict a lot of times, possibly detoxing if they have a co-occurring substance abuse disorder, and maybe medically compromised. There's also a very high risk of wanting to leave against medical advice. Groups at the inpatient level of care are oftentimes planting the seeds for change. Therapists may not feel very effective with patients at the inpatient level of care, and there's a high potential for clinician burnout at this level of care. Sparrow and Centuria found that inpatient-based groups are designed to help patients acquire the necessary skills for change and to provide an opportunity to practice social interaction and be supported by others with similar struggles. Group therapy as an adjunct to individual therapy on an inpatient ward may be particularly important, considering that psychological readiness and a self-initiated powerful desire to change have been identified as salient factors in the recovery process. The principal finding that patients value the social and practical aspects of group therapy suggests that it may be useful to encourage patients more often to attend groups, even if they're ambivalent at the beginning. The social setting of the groups may eventually assist patients' long-time recovery. And then briefly, groups at residential level of care. Population is typically less acute than on inpatient. The patients may still be going through the refeeding process, detoxing, still very ambivalent, and there's still a lack of motivation a lot of times. Patients are also at various stages of the recovery process. Because patients are less malnourished, typically in this setting, deeper process-oriented work can take place, getting to the heart of things. Patients are more receptive and willing to the idea of change. Smaller group size. So at residential, our residential specifically, we have a maximum capacity of 6, whereas on inpatient, I mean, we had an inpatient census at one point of 25. We were not doing groups with 25 patients all at once. We were splitting them up, but it's very, very different experience. So it's a lot more intimate. People are more vulnerable to disclose sensitive information in groups. Interpersonal dynamics play out more as the patient is less active, hopefully, in their eating disorder behaviors. So they're more agitated sometimes and more aware of how the eating disorder serves them in avoiding painful information and feelings about themselves and others. Exposure and response prevention approach implemented at residential level of care with more flexibility, which I referenced earlier, and increased intensity. It crosses all disciplines, so dietary, therapy, nursing, and the patient is an active member of the treatment team. Types of groups are the same: process, didactic, or psychoeducation, and experiential. I'm going to turn it back over to Elise to go over PHP, IOP, and outpatient.
Great, thank you. So I'll just briefly go over some of the population differences for clients we might see at partial hospitalization, intensive outpatient, and then outpatient treatment. So PHP population, they may still be requiring some weight restoration, but they're going to be mostly medically stable, so not requiring that 24-hour environment. Still needing quite a bit of structure around meal support and structure around, not engaging in purging behaviors and things like that. They may be partially motivated, but also still struggling with a lot of intrusive thoughts. At IOP, the majority of their meals here are going to be unsupervised. So they may have, 3 or 4 meals and 3 or 4 snacks per week in the treatment setting, and then the rest of them, they're working on building in their own structure and maybe outside support for those, and they're working on reorienting into everyday life. Now, this is for someone who's been stepping down through the levels of care. They're going to be now, okay, am I starting a job? Am I going back to work, going to school? Of course, some patients are going to just enter IOP and never attend the higher levels of care. So they're going to be kind of at different places. And they may be, continuing to work and go to treatment in the evening or something like that. And then, strictly outpatient here, they're going to be medically and psychiatrically stable. Motivation is fair to good. They're deepening their insight and doing longer term recovery work. And at all levels, populations can vary in terms of the stage of recovery process. One thing I'll note here is that at outpatient, that's where you're most likely to see clients really at the wrong level of care. You're not going to see somebody in residential who really should be at IOP because insurance isn't going to pay for that most likely, right? But in outpatient, we're going to be maybe seeing people coming in who really need a higher level of care. And one of the tasks there for the therapist is to be assessing that and recommending a step up where necessary. So the differences in groups here, as clients are moving through lower levels of care, treatment is providing less and less structure and containment. And so clients will likely start to experience more of a dissonance as their experience in treatment and in the group setting may be very different from their experience in their household or their family or their social groups. And, you know, they may be learning boundaries, but their family may not be quite on board yet, right? Or learning to move away from a diet mentality, and suddenly as they're spending more time with their friends, they're realizing that's all their friends talk about and that kind of thing. And so that's great processing material for group in these lower levels of care. And it's important, as there's less and less structure, to be supporting clients in prioritizing their own safety and containment. So, you know, they'll leave at the end of the treatment day, or they'll leave at the end of the group, and they won't have that, you know, 24-hour containment. And so assessing for safety, you know, if there's suicidality or self-harm urges, things like that. A lot of PHPs and IOPs will often incorporate a small group at the end of the program day, or just kind of a end of the day check-in around, like, you know, do you have any urges, and what can you do tonight or this week to try to keep yourself safe? What supports or resources can you call on? That kind of thing. Group topics at these levels of care can become more and more practical in some ways. For example, IOP might include groups around life skills, resume writing, interview skills. You know, we're not just recovering from eating disorders, we're recovering to a life. And so group topics might gear more toward, you know, life skills in that way. And there's a goal here for clients to be moving from that regressive space that I talked about, the arrested development, toward, you know, taking care of the practical realities of life. And then interpersonal learning in the microcosm of the group can actually be practiced in between groups with the client's family or community. So that's really powerful, because they can be, you know, seeing how they engaged in group, maybe try out something different, go practice that in life, and there's that in between in these levels of care. And, you know, lastly, at these levels of care, the groups are going to be more and more long-term. So groups at lower levels of care tend to have the same set or a similar set of clients for a longer period of time. And so groups are more likely to be able to develop into later group stages, like that working stage that Anna mentioned. And there's more opportunities because of that for certain aspects of therapeutic factors to emerge, such as, you know, there's going to maybe be greater group cohesiveness if there's a, you know, a longer term relationship there. And maybe opportunity for diving more into things like the existential factors, you know, the life and death and deep themes of, you know, the meaning of life and that kind of thing. So this is, I think Kristen mentioned some of these briefly, but these are the outpatient groups that Rock Recovery offers. Some of these are offered just in DC, Maryland, Virginia. Right now we have a body image group in California. But we offer meal support and process groups together. So these are 2 or 3 hour groups that include a meal and a process group. And they actually include additional services as well for people. So it can be matching with a mentor, chaplaincy. We have a chaplain on staff who can provide spiritual and faith-based guidance for clients who want to be integrating that into their recovery process. And it also includes individual goal setting meetings. So this is a great service for people who are maybe stepping down from IOP and want more of a comprehensive program to come into. Faith-based groups, we have faith-based groups to support clients who are wanting to navigate faith and recovery and how those two intersect. We have a moms group. So this is a life stage based group for moms navigating their recovery journeys, and then body image groups. So these are 90-minute groups to support clients heal their self-image. So that concludes our presentation. There were the references there, and this is contact information for us. So I'll turn it over for Q&A.
Thank you so much, Elise. So thank you both, Anna and Elise, for that great presentation. We've got quite a few questions that I'm going to try to get through in the next couple of minutes. So we've got them in between the chat and the Q&A. So I'll start with the chat, and then we can kind of go from there. So one of the questions that I see is, when group members ask the group leader if they've struggled with an eating disorder, what is appropriate for the clinician to disclose, especially if they haven't struggled? And could you maybe give an example of what could be an appropriate response in that situation?
Yeah. Depending on who you ask, you'll probably get a lot of different answers for this. I think that it can always be helpful to reflect back to the group what they think may be important for them to know about that. And that can be really illuminating, you know, what they're hoping to get out of hearing whether the therapist has struggled with an eating disorder. I also think if a clinician hasn't struggled, it can always be helpful to come back to those themes of universality, and to say, even if you want to share that you haven't, or if you want to kind of just come back to this space of like, I do know what it's like to struggle with shame, or, depending on how self-disclosing you want to be, you can draw on themes of eating disorders that everyone experiences, every human being experiences, rather than, answering whether you had an eating disorder or not. Anna, do you have different thoughts?
Yeah, I mean, our philosophy is we typically don't self-disclose, in treatment. Maybe in outpatient, I might be more willing to self-disclose certain things. But again, I do think it depends on the clinician, it depends on the program philosophy, but patients then will also tend to, they can externalize on the fact that you had an eating disorder or you didn't have an eating disorder. And I agree, like, why is this information relevant to you? I feel like what they're striving for is connection and understanding. So I really like what you said about putting it back on them of kind of, why is this so important for you to know? And agreeing that, at the end of the day, we're all human, although I may not have had the experience of having an eating disorder. I wouldn't say that directly, but, connecting to those underlying, feelings of like shame, worthlessness, depression. Like I'm a human and I can understand the human experience.
Thanks, guys. And thinking about treatment techniques and best practices, specifically as they pertain to binge eating disorder, do you guys have suggestions on what some good techniques would be for treating BED?
Yeah, I think the research articles that I read were mostly focused on bulimia and anorexia. There was some information about BED, but I do think it seems like CBT is the most effective, like evidence-based practice, at least for treatment of eating disorders. And it didn't really seem to matter which eating disorder. And then probably also some DBT as well. I don't know, Elise, what your experience or thoughts are.
Yeah, the things that come to mind initially for me are, DBT skills of emotional regulation and distress tolerance, and behavioral chain analyses can be really helpful in kind of being able to explore what all the links in the chain are between, trigger and acting on a behavior. That can really provide a lot of information. I think in terms of best practices, it's really important to be aware of the concepts of health at every size. If the client is in a larger body, and helping them navigate, with their other medical providers perhaps, or exploring the implications of social stigma that they might be experiencing. Not everyone, of course, with binge eating disorders in a larger body, but if that is a consideration for the client, those are things to be really mindful of.
We have a clinician who shared that they've found that after being in group treatment and receiving that peer support, that's often, as you guys mentioned, really helpful in the recovery process. After discharge, it's common for them to have contact with one another, for the group members to continue to have contact with one another. But at times that can turn into encouraging negative behaviors, to things like competitions with who can eat less, and just reinforcing some of those more dangerous behaviors that were dealt with during treatment. Can you comment on how an outpatient therapist could be helpful in this situation?
Yeah, that's tough. I've had clients who've moved in with people they were friends with in treatment and things like that. And it can be really tough. What I like to encourage clients to explore before, if I'm noticing that they're talking about a certain peer, and it kind of sends up a little red flag or yellow flag if they're really, if I've seen the eating disorders kind of compete, like I was mentioning. And I will bring that up pretty directly with a client and say, it can be great that you're getting support from, people who get it. And let's really kind of be mindful of what are your red flags for if this is becoming more negative than positive.
So 2 questions around comparison. I'm going to kind of group these 2 together. We have a clinician who asked, what are the main differences between ED and substance abuse disorders? And then underneath that umbrella of treating patients with eating disorders, what would be some differences that you both have noted in working with male versus female clients?
Yeah. I can speak for myself. I haven't worked specifically in just substance abuse treatment. I know in substance abuse treatment, the relapses potential is very high, as with eating disorders. I think really though, the way I conceptualize it is that the underlying issues can be the same. And a lot of them present with comorbid, co-occurring eating disorder and substance abuse. It's very common. And then in terms of males and females, so some of the body image pieces I feel like are different. And again, it also depends on, the specific population, like a cisgender male or like a transgender, patient, for example. So different themes may come up, and I feel like that's more specific to body image. But in terms of like the process-oriented groups and the way kind of treatment progresses, from my experience has been very similar. At one point, we were a male residential facility, and the treatment approach was the same. So I would say the biggest differences come up around body image from what I've experienced.
Yeah, I can second everything Anna said. A couple things I would add about substance use. Something that I talk with my clients about who have struggled with both is that, with substance use, oftentimes the goal will be sobriety. And that's not possible in the eating disorder world. So there's a lot more emphasis on, flexibility and not moving toward perfectionism of like, let me follow my meal plan to a T or things like that, because we eat food every day and we can't do it perfectly. And so, there's a real black and white, like, did you drink or did you not? That, the recovery is very black and white there, where in eating disorders, it can't be as black and white.
I would just like to jump in really quickly because we're almost at 2:30. And first of all, ask our presenters if they could stay on an extra couple minutes to continue to answer questions for any attendees that also would like to hang out. If anyone needs to go, we want to be respectful of everyone's time. So please, if you need to log off, I'm just going to reiterate, which I have in the chat a couple of times, that you will be receiving a copy of these slides with your after course email. Lenore was here. Bye, Lenore. Thank you for the note. And you'll have access to download a recording of this presentation as well. That will be, you'll get access in an email, and that'll be up for 30 days. And there have been, I'm just going to put this out for the presenters, there have been a couple of requests that popped up throughout the chat for book recommendations, a general sort of book recommendation request, and then one came in just specifically now about any book recommendations for Christian clients with eating disorders. So I just wanted to make sure that was noted. And if you had anything off the top of your head that you want to share, I'll put it into the chat now for folks that are still here.
I did see a question about what the book was that I was referencing about group psychotherapy, and that book is by Yalom. And if Kristen, do you mind going up one slide just for a second? It's Irvin Yalom. It's, I believe, called The Theory and Practice of Group Psychotherapy. Yeah, it's the bottom one there. So that's really, like, I think, one of the best books about group therapy in general. There are others, and then there's quite a few books I tend to recommend to clients and clinicians about eating disorder work. The 8 Keys to Recovery from an Eating Disorder, Eating in the Light of the Moon. Some of those have formed, a conceptualization of eating disorders. Anna, I don't know if you have any to add.
No, not at this time.
Okay.
Yeah. I mean, sometimes we'll utilize other books because, trauma-informed care books or different modalities. There's a specific DBT workbook that addresses anorexia nervosa and one for bulimia nervosa. So sometimes I'll utilize those, or I'll just use the standard Marshall Linehan old school book.
Yeah.
And they apply very easily to eating disorders.
And, Elise, you already referenced Health at Every Size by Lindo Bacon, but that's a great one as well, because, we know that fear of weight gain and fat phobia might not be at the root of every eating disorder, but it is certainly at the root of a lot of disordered eating.
Yeah.
And if you guys have other recommendations, you can send them to me or Fiona, and we'll include them in a follow-up email as well. So another question, and I'm excited to hear Elisa's response on this because I know Rock's philosophy. But are eating disorders something that patients will be recovering from for the rest of their lives, or can you fully recover from an eating disorder?
Yeah, this is also something that you will get different answers depending on who you ask. My philosophy and Rock Recovery's philosophy is that full freedom is possible, that we can be recovered from an eating disorder, not just in recovery. I understand definitely where other clinicians might have a different approach, just because it's wanting to maintain that balance of, guarding yourself against relapsing and things like that. I'll sometimes, depending on where my client is at in the recovery process, talk about like a cautious confidence. So we're still going to be cautious about certain things that might be triggers, but really confident that we're heading toward full freedom.
Same.
I was going to say, Anna. Thank you.
I have nothing to add to that. Same, yeah.
Yes, we definitely believe that full freedom is possible. But yeah, Elise, I appreciate you guys' answer to that question. I just had one. Are there any patients that have binge eating disorders that are only seen in inpatient care, or are those who struggle with BED seen in IOP and outpatient as well?
We've definitely had patients admit at inpatient and residential that have binge eating disorder.
Yeah, they're seen at all levels of care.
We had a question that I think is a little bit more specific to reasons because it talks about higher levels of care. So I'll share this for Anna. It's, I assume group therapists also do individual work. Is this correct? Are patients randomly assigned to the individual therapist, or is there some paradigm or protocol?
So yes, the individual therapist is also running group therapy. So at residential, we have 3 therapists, including myself. So as a program manager, I also run groups and will carry patients at times. And the same on inpatient. We have usually like 7 to 8 or 9 therapists, and all of them are running groups and carry individual patients as well. At residential, with there only being 3 of us and 2 therapists who typically are carrying the load of the patients, we don't have a lot of flexibility in how we assign patients, only because when one person discharges, that therapist has an open slot, and then we assign the oncoming patient to that therapist. However, on inpatient, when I was program manager there, I was a lot more thoughtful in how I assigned patients to their clinician.
I think both of you guys will have different answers to this question, so I'd love to hear from both of you on this next question. What are your program's philosophies related to follow-up and contact after treatment? And Elise, if you want me to expand on a little bit on what we do at ROC specifically, I'm happy to do that as well.
Yeah, that would be great.
Review. Well, I can start with ROC Recovery. So with our groups, like I said, we're clinical outpatient therapy groups. And what we typically do is when our clients graduate from our programs, there's a survey that goes out that measures their success in the group and how they've come along throughout the treatment process. And this is something that's sent out during their time in the group as well, along with the individual goal setting that they do with the therapist and things like that. And then additionally, we check in with our alumni about every 6 months for their first 18 months out of recovery, just to make sure that they so if they need any additional resources, if they need to get reconnected to your group or things like that, that's how we maintain connection with anyone who might need additional support. And then Anna and Elise, if you guys want to answer that as well.
Yeah, and Anna, likewise, I can speak to our alumni program if you want to briefly just sort of speak to the parameters that are put around contact with the clinical team.
Yeah, so typically, I mean, we do have all levels of care. So it's very often that they'll go through all levels of care with us. So they can be in our program up to a year, almost going through levels of care. So there's a lot of follow-up in that way. Clinicians aren't really encouraged to have contact with the patients after the patient discharges. So the marketing team will follow up from an alumni perspective and continue communication and support with them, but none of the clinicians are really following up with the patients post-discharge.
Mm-hmm. Yeah, and the outreach team, exactly as Anna said, we have a fairly robust alumni program at Reasons. We do wellness checks for our alumni, similar to what Kristen was describing, that follow-up. Ours are typically a few weeks post-discharge and then a second one a few months post-discharge. They're provided with information about our alumni programming as part of their admissions packet, but we also understand that there's so much going on when you're admitting into a treatment program. You're likely malnourished, you're in a really immersive environment focusing on quite a bit. So that can easily get lost in the shuffle. And one of the primary reasons for our wellness checks is to just let people know, hey, don't know if you remember, but we have an alumni support group that we run once a week. Currently it's virtual. We might be opening up a second virtual support group in the evenings because we've had some requests for that. We have a private hidden alumni Facebook page that no one, you can't access it without an invite. No one can actually see it or see who members are unless you're part of the group. And that's a really nice forum for our alumni to be communicating with conduits at Reasons, myself and my team, and to give updates about groups and events. We've done a couple alumni virtual retreats. We did 2 this year post-COVID online, which were really wonderful. And yeah, the events in person we're hoping to do again at some point, but obviously we're being cautious about that right now.
Thanks, guys. And Anna, I think you made a really good point of mentioning that we also, at Rock Recovery, we also separate. Our clients do not maintain, or excuse me, our clinicians do not maintain relationships with our clients after graduation. That's done. We have a separate alumni group, and I am not a clinician, and I have the pleasure of working with our alumni once they leave the program. So I think that is an important point to note. All right, so we have 3 more questions to get through. One of the clinicians asked whether the programs address ARFID. They've seen this at different levels of care. So I don't know if you guys want to talk about how it's different, maybe treating ARFID in a group setting.
Yeah, I think we do. And I think this is an example of a time where maybe there can be that sense of like non-universality, right? Or sort of an otherness, because an ARFID client is going to present a little bit differently than maybe a typical eating disorder. So that can be something that comes up, I think, in group therapy with those with ARFID. And it's, again, important to kind of come back to, the behaviors might look really different, but underlying, do we have some of the similar functions of what's coming up with the eating disorder? Do you have anything to add, Anna?
No, I agree. Yeah, we recently had someone, we don't see it as often, but we recently had a residential patient with ARFID. Yeah, and just feeling like other. So I think most of the patients in the group can relate to that, feeling other in some other way.
Right.
So that's like a common theme, to connect on.
Yeah, and I would add that our exposure with response prevention utilization really fits well with an ARFID diagnosis. That's a great modality to be using with ARFID. And above and beyond my experience at Reasons, having worked at other treatment programs as well, we see it much more frequently in a younger population and with adolescents, but it's an interesting thing to look for with adults who may in the beginning present more with a binge eating disorder type presentation, where when you start to unpack it, you realize that it's actually that they have a very, very limited palate, and they're unable to access their preferred foods for the most part during the day at work, for example, so that the binge really comes along with having access to that limited diet that they will eat. So I think it's a really interesting thing to look for if you're working with adults with binge eating disorder that might be kind of lingering underneath, that they wouldn't necessarily have recognized in themselves either.
Thanks, Fiona. So this probably depends on the group, but when you have a multitude of different subjects that could be explored in a group, which is very common when you're in a group setting, you have a variety of clients with different backgrounds coming to the group. Are there any considerations when deciding which topics you should prioritize or focus on?
Yeah, I mean, I can speak a little bit to that at the inpatient residential levels of care. I think number one priority is safety of the group. And that can kind of be subjective, I suppose, to the therapist leading the group. We have a lot of flexibility in terms of what groups we lead. There's been times where we've completely stopped program before if there was something, of very much importance that needed to be addressed. Patients maybe are not engaging in their groups. So it really just depends on what the group and milieu is needing. And then basing it off of that. I don't know if that helps at all. Our process groups do have themes. So there's shame, there's anger, honesty, and integrity. But if something is happening in the moment, we'll kind of change the group to address whatever's happening in the here and now.
Yeah, I have similar thoughts on that, and I think it is always important to, whenever we may have a topic or directive going into a group, to be able to be flexible and kind of flow with what's happening in the here and now in the group is always really important. But I think considerations for choosing a topic can be a lot of things, a lot of different factors, but really looking back on, what Anna shared about the stages of group, it can be really helpful to be able to recognize like where is my group at in these stages, and what topics are going to be accessible to a group in more of the early stages versus later stages.
I think also sometimes there's a lot of interpersonal dynamics happening that may trump whatever we were planning on doing.
Right.
So needing to address those as well. So it's really kind of up to the clinician, and for newer clinicians to consult with someone who's maybe more experienced to get guidance around the direction to take, because it can quickly get out of control.
And then our last question is, you guys talked a little bit about self-disclosure when it comes to the clinician's personal background with mental health, their experience, their upbringing. Do you self-disclose about faith issues in a different way that you would with like if you were like recovered from an eating disorder or something like that?
So at Rock Recovery, we are a faith-based organization, and we also serve clients of all faiths or no faith at all. It may not be important to them, right? And so and we, in groups where there may be a diversity there, that's something that I would typically not self-disclose about, because I would want all clients who are there to feel safe, and to not have that affect their process at all. However, I did mention there is a specifically faith-based group that we have, and so in that group, that might look a little bit different, because you have an awareness that all the clients are there for that reason.
Yeah, typically we don't self-disclose anything, which maybe can feel a little cold, but I mean, it's not, but we just don't want the patients to externalize, especially on the higher level of care where externalization is kind of a go-to to distract from whatever's happening with them. But if the therapist is feeling like a desire to self-disclose, I always, sorry for the dog barking, I always just encourage them to seek consultation in terms of sometimes there's countertransference issues that may come up. And if we have had our own struggles, we can actually use our countertransference in a way that's very therapeutic to help the clients. But, sometimes we may need guidance around how to do that.
Right. Yeah, I think self-disclosure in groups is a lot more complicated than self-disclosure in individual, because you have to be aware of what are the risks of self-disclosure for 8 different people versus one person. So it is definitely trickier in group therapy.
Well, thank you. And thank you to the 40+ people who hung in for an extra 20 minutes with us to hear Anna and Elise share their wisdom. Really two wonderfully experienced individuals here when it comes to running groups and working in different settings across the sort of treatment paradigm. We just feel really lucky that we got you two together. I'm really grateful that you wanted to do this, and I hope everyone enjoyed, and we'll see you at the next go-round.
Thank you,
Thanks, everyone.
Bye, everybody.
Bye.